Yeah. Okay, good morning, and everyone. I guess I'll meet down a little bit. We have a special VVP rounds today, and we've got Dr. Andrew Lee from Houston. Dr. Kathy Chow will be doing his formal introduction. But I got to tell the online audience of our faculty that I've witnessed one of the most amazing things that I've seen from a visiting professor, which is he's already learned all of our residents' names. More than I can say for some of our faculty. This only took him 15 or 20 minutes. This is quite impressive, actually. And this is why he's a neuro-ophthalmologist, right? Like you're just the smartest ophthalmologist. But Kathy, I'll let you introduce it formally. And Andrew, thank you for joining us.
Thanks, Indeed. Really appreciate it.
So I'm sure a lot of you know Dr. Andrew Lee is chair of the Bolton Eye Institute in Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas, and is professor of ophthalmology, neurology, neurosurgery at Weill Cornell Medicine. So aside from his title, I'll just tell you a little bit about the Dr. Andrew Lee that I know. He's actually a very good friend of mine. He's world-renowned neuro-ophthalmologist, traveled to over 100 countries in the world, given over 400 talks, and has, from the neuro-ophthalmology perspective, a leader. And now, a lot of you may not actually know, he's also a leader in medical education. So this is the CanMeds Grand Rounds. So we're trying to teach here today is effective teaching. Actually, just before what you guys have already witnessed is some of his outstanding teachings. So not only has he published books on effective teaching, he himself is just a personification of teaching. All the residents now, what you're going to do is you're going to go online and look up his YouTube video. So he actually has over 100,000 subscribers to his neuro-ophthalmology YouTube channel, and has just recently passed 8 million views. So not only is he a world-renowned clinical teacher, he's also a famous personality. So by the end of this lecture, before the seniors, I know some of you will have to go to surgery. So before you go, we're all going to take a selfie with Dr. Lee at the end of his grand rounds. Okay, so before you go, we'll do that. So now I'll hand it over to Dr. Lee.
Thank you so much, Karen. So I'm going to be talking about teaching, but really timing teaching and triaging in the neuro-ophthalmic clinic, because we're all overwhelmed, underpaid, and overworked, are we not? And so at the end, we're going to be going ad meliora, which means towards better things. And one of the things I hope you've taken away right away is the point of learning your names is that we are now quantumly entangled. One day in the future, when I'm not here on this planet anymore, you will attempt to do what I just did for you. Learn the names of every person in the lecture hall that you go to when you are the Grand Round speaker. And if you do it, we will have quantum entanglement. That means something that happens now will affect something that's going to happen in the future. Like a right and left boot, we are inseparable now. We are bound together in time and space. There are very few things that can transcend time and space. One of them is gravity. The other is love. You feel that love. You have a love for people who are long perished from this planet. Your grandmother, someone that you know who is gone, but you still feel them. Is that not true? It is quantum entanglement at a cellular and neurobiologic level. And in the future, we will maintain this quantum. You'll see, I promise. One of the things I hope you're going to take away is you need to read. Your peak reading occurred when you were 2. After that, literally, in the United States of America, 3/4 of Americans have not read a book in the prior year. So don't be dumb like Americans. Some of your professors are going to try and convince you that they had it harder when they were you, that we had to trudge all the way uphill in the snow both ways. This is my BCSC books. This is yours.
Don't tell them that.
Double the amount of knowledge to know. The doubling time on information is increasing exponentially. The doubling time for ophthalmology knowledge is about 5 years now. So what I've been asked to talk to you about is teaching, but really optimizing your timing and your teaching and how we do it in our neuro-op clinic. And I hope that you'll take away some best practices from this. We teach before the clinic starts. We call that pre-charting. So the resident and the fellow and the medical student look at the chart the day before the encounter. You guys have electronic medical record? So they already know that I'm gonna ask them stuff, but they already know the answers. And they look super smart in front of the patient, even though yesterday they were dumb. They didn't know anything about that disease. But when they get in the clinic, the patient thinks they're a genius because I am asking them questions that they looked up the night before. Don't you want to seem smart in front of the patient? Because the way you're being taught right now, your attending asks you stuff, you don't know the answer. And you look dumb in front of the patient. And you call it pimping. I believe in pimping, but I also believe in priming, okay? Priming and then pimping. I want you to look good in front of my patient. I want them to think this is the smartest resident, Dr. Lee, I've ever had. I've been coming to this hospital for 20 years. That's the first time the resident knew every question that the attending asked. But the resident and I know the truth. They pre-charted with purpose. And that purpose was to find the questions that I'm going to ask them. I already tell them what the questions are in advance. Symptom, sign, the tests, the treatment, and the prognosis. These are the questions. It doesn't matter what the case is about. I'm going to ask them, what's the most important sign here? What's the prognosis? What treatment would you give? The questions are known in advance. We focus on a chief complaint, and that we call the in-chart phase. The way you've been taught how to do the chief complaint is like this. Chief complaint, blurry vision. Isn't that what they taught you? Put it in quotes, whatever the patient says. That blurry vision could be nothing. That could be glasses. That could be dry eye. That could be you have a pituitary adenoma. It could be you have an aneurysm and are going to die today. Blurry vision is a stupid chief complaint. I'm going to show you what a clinical stem, a focus stem looks like in our in-chart. And then we have hypothesis generating and hypothesis testing driven encounters, which means during the in-chart phase, we are generating hypotheses. A differential is generated and a plan. And then in the post-chart phase, the labs, the x-rays, the resident continues to monitor the chart, even after the patient has long left the clinic, because they're testing their hypothesis. And I dictate in the room contemporaneous to the visit so that the patient hears everything that I'm thinking of. In the future, ambient listening will do this for us, and then it'll just generate an in-chart. You have this already, ambient listening? It's AI driven. The dictation is generated just from you talking to the patient. Takes out all the small talk, it just goes straight to the dictation. You template it and it learns to type exactly what you want in the way you want. And it teaches both the patient and the learners in real time. So I get the patient to try and be the teacher. And I always thank them at the end. Thank you so much for teaching these young people about your disease so that they know they're not a guinea pig, that they're actually a participant in the process. And the teaching continues the next day. So we talked about tamagana. You are that Japanese iron. It's special iron. It's high carbon. It's going to become katana steel, a sword that is flexible and strong. But what it requires, and what does it require, Wissam, to take tamagana to katana? Pressure and heat. Heat and pressure. It is heat and pressure that turns a lump of metal, Wissam, into katana steel. And at the end of the day, the litmus test for me, would I take this resident into battle with me? Is this katana with me, or is it a fork? I need a fork. I have to eat dinner. I need a fork. I need a spoon also. But somebody's got to be katana. Yes? Everybody needs a fork. There are plenty of forks in this world. You decide for yourself whether you want to be a dinner fork or you want to be katana. It's choice. It's choice. The heat and pressure, though, if I heat it too hard, too hot, and too long, if I hit it too hard, what will happen, Wissam, to my sword?
It'll break.
It'll break. And therefore, we heat it till it's red hot. And then what do I do when it's red hot?
You cool it.
No, I hit it. I hit it with a hammer. And what happens? Sparks fly off. All the impurities are being driven out by that hammer. Do you understand why you have to hit it on an anvil? So you heat it Red hot, you gotta hit it. Bad unlearning of bad things comes out. All sorts of bad habits comes out. Yes, teaching of other physicians and other faculty members who gave that person bad teaching has to be struck out of them. Yes? Okay, then comes the cooling and the quenching phase. So I don't ask them anything at the end of the encounter. I say, go read on that. And tomorrow, when they're fresh at 7 a.m., they've read the whole thing. And not only did they get to impress the patient in the pre-chart phase, they get to impress their peers in the post-chart phase because they've looked it up. Because I told them to look it up. And we already know what the hypothesis is because they heard what the hypothesis was in the dictation. And they heard what I was thinking. Do you understand what quenching looks like? And then we do that the next day. Because at 5 o'clock in the evening, everybody wants to go home. Nobody wants to hear me drone on about anything. Everybody wants to go home, including me. And therefore, I block 7 to 8:30 every morning. No patients yet, just for this. We also use that opportunity for the post-charting because some of the labs and x-rays are already coming back. Maybe this doesn't happen in Canada, but we already starting to get the results day one. And then the best cases from morning report become grand rounds. But not that week, in 3 weeks or 4 weeks. Each learner is assigned their best case to present at grand rounds. And then that becomes a case report. And then that becomes an iWiki. So every learner gets at least 2 papers at 2 iWikis and 2 grand rounds for their CV. And we let the medical students take first crack at it. So we have 2 presenters every week. The medical students present, and that means we have 2 papers being generated every single week. I've written a paper every 3 weeks since I graduated medical school. I'm not the first author on any. Say, okay, yeah, format it, use the template, yeah. Spell check, grammar, all that's done automatically. I don't do any of that. Reference verification, all done. Formatting, all done. All I do is say, you know what? I don't think you have the focus here right. This needs to be fleshed out. You need a table here. So it takes me about 5 to 10 minutes to review a case report that learner literally spent 3 or 4 days writing. You understand what my job is? When I was a young faculty member, I would red pen every paper and rewrite it. I don't do that anymore. I don't. Every day we are in battle against the Reaper, the Green Reaper. Your job is to keep the Reaper at bay. The Reaper is coming for everyone, including you, for your patient's eyes, for your patient's life. It's coming for you too. In the end, the Reaper always wins, but it doesn't have to be today. Not today. It doesn't have to be today. It's coming for your very professional soul. The way he comes for you is called burnout, physician burnout. The Reaper wants you. This is burnout by specialty. That's the average. You can see ophthalmology right there. We are 43% burnout under Maslach burnout index. It's not like I said I was burnout, that they were objectively tested for emotional disconnection, depersonalization, real burnout indices. Now, we're not as bad as emergency medicine or neurology, but we ain't no dermatology either.
Damn it.
I cannot do anything about your exhaustion, your depersonalization, but what I can do something about, and I think the reason I'm here today is to help you feel a personal accomplishment. I want you to leave here inspired. I want you to feel that the depersonalization, the emotional exhaustion, and the moral injury that you feel every day from the system and the man beating you can be overcome with personal accomplishment. That is my goal for today. I cannot do anything about your bureaucracy, your hours, feeling like a cog, too many difficult patients, like your taxes. I can only do that. That's all I can do. So how are we going to defeat the Reaper? It's a larger question that I hope that you'll think. When I go to the movies, I rate movies by, did it make me think about it? Am I still thinking about that movie tomorrow or the next day? That's the goal of today. That you're thinking about today, tomorrow, and the rest of your life. So the components of great teaching and great feedback require 3 elements. It has to be timely, it has to be accurate, and most importantly, it has to be actionable. I do not give feedback to my learners without action attached to it. A lot of your feedback is timely. That's not the right diagnosis. Is accurate. You didn't detect that corneal ulcer, but you didn't have any action item to fix it. Yes? So hopefully any faculty who are on here, you must follow these rules. How many times do you hear this? I don't really have time to give you a formal feedback review. You're doing fine. When you're not, I'll tell you, you're doing great. Or it might sound like this, you need to read more. Or it might sound like this, you'll get it eventually with effort and time. It just takes experience. Isn't that what you hear? So if you're a faculty member, please don't do this, okay? Must be timely, accurate, and actionable. Actionable is the key word. I'll show you what that looks like. So of course, feedback has to work for the learner. It has to work for me. It has to work for my calendar. And it has to work for my watch, which means it has to be short. And that means for our feedback sessions, I insist that the learners bring their own feedback first, pre-chart. Then we have in-chart, then we generate hypothesis, then we test hypothesis, and then we have a post-chart feedback. Did you do the things I asked you to do? Most of your feedback sessions have no follow-up. It's just, well, time for your feedback. How do you think you're doing? I think I'm doing okay. Yeah, me too. You're fine. You're doing great. We really appreciate you being in this program. Thank you so much. You're doing good. You know, you could read a little bit more though, but that'll come with time and experience. You'll see. You're doing great. That's crappy feedback. Okay. I love this Dr. Seuss thing. It says, I will teach you in a room. I will teach you now on Zoom. I will teach you in your house. I will teach you with my mouse. I will teach you here and there. I will teach you because I care. This is me. I have a treadmill desk. So our morning report is my exercise for the day. I walk approximately 2.5 miles during the 1.5 hour encounter in the morning. My exercise for the day. So how do we pre-chart? We pre-chart because we have Epic. What do you guys have? Epic. So Epic has a pre-chart option. And it'll say this, would you like to pre-chart on future encounters? Never ask me this again. Of course I do. Yeah. So we just made that a default. So in the pre-chart, the patient has not arrived yet. The learners have already accessed the entire record. They have cut and pasted all the relevant information into the sections. They have generated a hypothesis, and my whole job is test their hypothesis. That's my whole job. So I want to show you about what pre-charting looks like in a clinical STEM. This is Abraham Lincoln. This is Winston Churchill. They were both outstanding speakers, but they also used focused STEM, a focused clinical STEM. So Marco, I'm going to give you a STEM. Ready?
Sure.
It's an 80-year-old white female who has headache, scalp tenderness, jaw claudication. She's no light perception, has an RAPD and pallid edema. Diagnosis.
GCA.
That's a focused STEM. What if I had said 80-year-old blurry vision? You have no idea what that is. Yes?
Yeah.
Nina, it's a 20-year-old white female with acute unilateral loss of vision, pain with eye movement, RAPD, normal fundus. Diagnosis.
Multiple sclerosis, optic neuritis,
Most common neurologic disorder. Best treatment.
steroid, pulse steroid.
IV or oral?
IV.
Prognosis?
Better.
Yeah, it is better. What's gonna happen to their vision?
Well, it's gonna recover, but it's gonna relapse again.
You understand how fast you can get to the answer with a focus stem? Yes? What if it's blurry vision? That's a sucky stem. This is Lincoln's Gettysburg Address. 77 years ago, our fathers brought forth onto this continent a new nation, conceived in liberty and dedicated to the proposition that all men are created equal. Pretty good focus stem, don't you think? 77 years ago, what happened in our country 77? That's 87 years before the Civil War, Revolutionary War. A new continent, conceived in liberty and dedicated to a proposition that all men, not just white landowning men, all men are created equal. Don't you think this is a good topic sentence for what I'm about to tell you if I'm Abraham Lincoln? Do you believe in these words or not? Is that not what he is asking the audience? And Abe Lincoln in a PowerPoint would suck. It would look like this. Here's the review of the objectives that I'm going to cover today. What makes our nation unique is it was conceived in liberty and men are equal, as you know. We have a shared vision in this audience today, new birth of freedom, and the government is of, by, and for the people. If you look at our organizational overview, 87 years ago, we had nothing, and now we have something. We are met on this battlefield to dedicate a portion of that field. That's fitting, but we have some unfinished work. So in summary, we have a new nation. We're fighting a civil war. I'd like to dedicate its field to dedicated unfinished work to give a new birth of freedom so our government won't perish. Thank you so much for your time and attention. You understand how PowerPoint would totally destroy the Gettysburg Address and every speech you've ever heard and every song you've ever seen. Have you ever looked at lyrics of love songs? They're stupid. Yes? They're stupid. But when they're sung, aren't they beautiful? Don't they touch you in a way that the words themselves are usually stupid. Like half the words are yeah, 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 or la, la, whoa, 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 or yeah, yeah, yeah. The actual speaker at Gettysburg, November 19th, 1863, was this man, Edward Everett. Edward Everett was widely considered the best speaker of his day. He spoke for 2.5 hours. Abraham Lincoln's Gettysburg Address is 2.5 minutes long. Edward Everett, the other speaker at Gettysburg that day, said this in a letter to Abraham Lincoln: "I should be glad if I could flatter myself that I came as near to the central idea of the occasion in 2 hours as you did in 2 minutes." So come visit me on YouTube. In YouTube, we try to capture in 2 minutes what has not been captured by you in 2 hours of reading it over and over and over again. You understand what I'm trying to do. So how would Lincoln present John Cell? Marco. This is I just read it.
Horse, 87-year-old,
87-year-old white female with
acute painful, vision loss, headache, and jaw pain, NLP, she has a RAP, and a pallid edematous disc in the right eye.
So when the resident comes into the room, I expect to focus them right from the start. I want them to pre-chart with purpose. Shouldn't they say that to me in the first 30 seconds of the in-chart encounter? This is Churchill, June 4th, 1940. We shall fight. We shall fight on the beaches. We shall fight on the landing grounds. We shall fight in the fields and in the streets. We shall fight in the hills. We shall never surrender. Come and get us, Adolf, if you dare. You understand what the power of the prose is now. What makes songs songs, and what makes love in love songs love. This is how Churchill would present idiopathic intracranial hypertension. Idiopathic intracranial hypertension is elevated ICP without a cause. You can only have symptoms of elevated ICP. You can only have signs of elevated ICP like papilledema, non-localizing cyst. You can only have an MRI and an MRV that shows the radiographic findings of elevated ICP. The lumbar puncture has to be normal and can only show elevated ICP. It is a diagnosis of exclusion. You must rule out other causes of elevated ICP. We shall never surrender. However, the way they teach you the modified Dandy criteria for idiopathic intracranial hypertension, Churchill would have ripped that up and said, you need to have elevated ICP in every one of these criteria. Do you understand the difference between a Churchill and a not Churchill? So, Josh, this is a 25-year-old obese female who has migraine headaches, pulse synchronous tinnitus, transient visual obscurations, and bilateral papilledema. What do you think this is?
Age.
He only has symptoms of, you're only allowed to say elevated ICP.
Elevated ICP.
You only have signs of,
Elevated ICP.
the MRI and the MR venogram showed empty cell of fluid in the sheath, flattening of the globe, and venous sinus stenosis, but no thrombosis, and only radiographic signs of.
Elevated ICP.
A lumbar puncture was performed, which showed normal CSF content, but the opening pressure only showed.
Elevated ICP.
And therefore, the diagnosis here, Josh,
IH.
not a trick. What's a treatment?
Weight loss.
Weight loss and water pill and watching you. What if it's 2200 vision, RAPD, going blind?
Surgery.
Surgery, the knife. Boom, 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 boom. Yes, that's a neurop case that would take 5 minutes. Yes, because the stem. And then Josh is in the room with me and the patient and just boop, bop, 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 bop. I say, good job. Josh, what do you want to do with this patient? Weight loss, Diamox, if there's no contraindication and they're not allergic. What's going to happen to this patient, Josh? They're going to get their vision back. Probably, but we should see them back. When do you want to see them back, Josh? In 3 months, make sure the disc edema goes away. And then the patient will interrupt and says, this guy is the smartest resident I've ever had at this hospital. Do you want to be katana or not? Or you can be a fork or spoon. So in our clinic, we use the scientific method. Yes. Symptom, sign, question, hypothesis, test, analysis, repeat. The scientific method. Every new patient at every first visit, we end with hypothesis generating, and then we order labs, x-rays, hypothesis testing. Each resident of that case is assigned to follow up on the hypothesis and either modify the hypothesis or reject the null hypothesis. Your hypothesis is an educated guess. It is the scientific method. You need to use it. The most common errors that occur here are premature closure of the differential diagnosis. Who's the most likely to do that? Ophthalmology. Impression, cataract, plan, cataract extraction. Impression, retinal detachment, plan, put retina back on. Impression, glaucoma, plan, add a bunch of drops. Impression, ptosis, plan, ptosis repair. No hypothesis, no differential. Is there a differential, Brian, for ptosis?
Yeah.
What if you write impression, ptosis, plan, ptosis repair, and it comes back? You'll end up writing this, impression, recurrent ptosis after ptosis repair. Plan, Brian, what is my oculoplastics person write after that? It came back after surgery. Recurrent ptosis after ptosis repair. They write failed ptosis repair. What do you think they write as their plan? Repeat ptosis repair. Okay, patient comes back, failed, repeat ptosis repair. Plan, neurop. Isn't that what it is? How about impression ptosis? I looked for signs of myasthenia. I asked about symptoms of myasthenia. I'm not gonna let this person get a recurrent ptosis. How about impression ptosis secondary to levator dehiscence? High indistinct lid crease, normal levator function, no evidence variability and fatigue, no systemic symptoms of myasthenia, plan surgery. Isn't that what you're supposed to be doing? They don't. Mohammed, Impression, age-related macular degeneration, dry. Plan? Yeah, that's what they write. That's what they write. Except impression, age-related macular degeneration, vision worse. They do OCT, macular dry, fluorescein angiogram, no leakage. Plan? Neurop. Where's your differential, man? Yeah. Where's your note? Impression. Samira, impression. They see the nerve is pale. What do they write? Impression. A pickle optic nerve. Plan. What medical school did you go to? Yes? Impression, pale nerve, plan, neurop. You have to have a differential. Yes? You have to have a plan. The plan cannot be neurop. That's a stupid plan, by the way. What's the next available neurop in Toronto?
The next day.
Next day.
The next day.
Yes.
Wow. Next available use of the test is neurop, 6 months. There is no next day. You are neurop. You are neurop. We don't have next day neurop. We do not. I'll show you why that is, by the way. So every follow-up patient ends with the prior hypothesis generating and the prior hypothesis testing, and then we start again. Every time. So we have a null hypothesis. That's what science is. And weirdly, the null means no relationship. So Yusuf, if you think it's giant cell, what is your null hypothesis?
That there's no GCA.
That is not GCA. And so are you going to accept or reject the null if you think it's GCA?
You're gonna accept the null?
No, what's the null?
Not GC.
Oh, it's not GCA.
That's so weird that they teach it to you like that. So by rejecting the null, yes, you're saying a double negative. There is no no. That means it is giant cell. That's so weird, don't you think? And that's the nature of science. We're skeptical of everything. We always start from the proposition that it's not something, right, Brian? So instead of writing ptosis, your proposition is not myasthenia. Yes? Not corners, not a third nerve palsy. You must have a null hypothesis before you accept levator dehiscence and operate on a Horner syndrome. So we test the hypothesis, and at the follow-ups, the patients are either better, worse, or the same. That's the hypothesis. All right, here's the hypothesis here. Man lung. It's Danny DeVito. He's telling Arnold Schwarzenegger, congratulations, because Arnold told Danny DeVito, I am. This is the null hypothesis, yes? The null hypothesis is, Arnold, you're just fat. You're not pregnant. So we can either accept or reject the null hypothesis, man lung. There's two types of errors we can make. Type 1, which is
False positive.
and a type 2.
False negative.
Okay, so Arnold Schwarzenegger comes to you and says, hey, I'm pregnant. What would be,
Type 1, false positive.
or it could be that they actually are
Or,
pregnant and you said they weren't. Yes? Okay, so you understand what type 1 and type 2 errors are? All right, so, hey man, your beta HCG came back positive. Congratulations. Your, what kind of error is that?
So, type 1.
Okay, and so what's a way more likely cause? You got your labs mixed up with this lady. You have the same name. Yeah? Or maybe you have an underlying germ cell tumor that is producing that beta HCG, and you do not have a pregnancy. You have a tumor that's secreting beta HCG. So literally, we do pregnancy tests on young men sometimes, man lung. Supracellular mass in a young male is dysgerminoma until proven otherwise. I'm literally about to do a beta HCG and an AFP, alpha fetoprotein, pregnancy test and an AFP pregnancy related test on a man. And they come back positive, dysgerminoma. You with me on this? Did you tell this lady your beta HCG came back negative? I don't know what that thing kicking in your belly is. What kind of error is that, man?
Type 2 error.
Yes, so at parties sometimes, there are ladies there, they could be pregnant, but maybe they're just fat. I never go up to them and assume that they're pregnant. I always let them tell me they're pregnant. The worst thing you can do at a party is say congratulations to a lady that she's pregnant when she. So at our initial hypothesis, we generate a hypothesis. In the post-test, we test that hypothesis. And at follow-up, we only have a single question. The single question that I'm going to ask the resident the next day, they already know the question, better, worse, or the same. I might literally walk into the room and just say, better, worse, or the same for my follow-ups. And if they say same, I'm going to say, let me see the OCT and the Humphrey. If it's the same, I'm going to say, you're doing great. You don't have anything else you want to tell me? No? Goodbye. 5-minute encounter. You understand how fast that makes the encounter if the hypothesis is you're the same. All right, here we go. Olga, this is a 54-year-old white female with new onset right temporal pain and tenderness. She had migraine in her 20s, and she has this inflamed artery on the side of her head. What do you think?
I'm thinking that she's too young for GCA.
A little bit young for GCA, don't you think? So you have a null hypothesis and you have an alternate hypothesis. Is this just someone who has giant cell and they're young? Or is this someone who has migraine and it just happens to be in their temple? Great chart. And so I tell our residents, you are moving from here to try and get here. First-year residents are unconsciously incompetent, which means they don't know what they don't know. And then they become unconsciously competent. That means they have to move through conscious incompetence. And what that means is, I don't know this, but I'm going to look it up in the pre-chart phase. And then eventually, you're just totally unconsciously competent because you move through all these phases. Do you understand? You have to pass through phases. Katana, it takes heat, pressure, holding, quenching. You cannot just go from incompetent to competent in a day. That's not going to happen. This is prisoner parole request. Michael, you see this, Michael?
See it.
In the morning, your chance of getting paroled is high. However, the next guy's goes down. And then next guy. And how about the guy right before lunch? What do you think that guy's chances of getting lower? And then after lunch, the very first guy gets parole. And then we take a break. How about the guy right before the break?
Unlucky.
Why? Because it's easy to say no to a parole. It's hard to say yes. You're about to let someone out that could commit another crime. Yes? So the burden of proof on parole is this guy going to be back here? So it's so easy, Michael, to say yes or no.
No.
It's faster. So if you're this guy right here before the break, say, you know what, we have 3 minutes before the break. What do you guys think about this? Should we talk about this case any longer? What are they likely to say?
No.
No. And God help you if you're here. Who is asking me this, Michael, in my clinic? Prisoners? No, who's asking me?
Residents want the feedback.
Hey, Dr. Lee, would it be okay if you give me some feedback today after clinic is over? You know, I really gotta get going here. I'm going to Toronto and yeah, it'll be real quick. What do you think I'm gonna say? No. Yeah? So don't ask me anything. You're gonna ask me something in the morning before we start. Please don't ask me anything right before lunch. Please don't ask me anything without giving me a Snickers bar or some kind of bribe. If you want to come for a feedback session, you better have a bribe. Yeah? Food. You're not you without the snickery bun. You're not you when you're hungry. Paul, I do not allow the residents to ask me for anything, let alone feedback, if I am hungry, angry, late, or tired. Talk to the hand. Oh. Hey, Dr. Lee, this is real quick. They're walking with me. I'm trying to go to the bathroom. Yeah, come in here with me. They're standing behind me. How do you think I'm doing on this? What? I'm peeing. Don't you find that horrifying that people would follow me into the bathroom to ask me? Yes?
Yes. I'm sure someone's done
Sorry, this is
someone must have done it.
my treadmill. Okay. 7 a.m. to 8:15 a.m., 2 miles on the strip. Because all the learners are on there. I don't have to do anything. They're talking to each other. They're teaching each other. I just unmute myself. What do you think the most common cause is? Mute. Like, what? Yes? All right. This is an Eisenhower matrix, and it's what I do every day. I decide whether things are urgent or not urgent. It doesn't matter if it's important or not important. You must do something with it. It's urgent to someone. So if it's urgent and important, I just do it. If it's urgent but not important to me, I delegate it. You need to ask my secretary about that. Please schedule an appointment with my secretary. It's urgent to them, or they're just waiting for me to say proceed. They're not actually asking me anything. They're just waiting for permission to go forward. So I just say proceed or good job or okay. All they're asking from me is acknowledgement that I received the message. What if I don't write back? They'll say, well, it's stuck on Dr. Lee's desk. I know he's looked at it, but he didn't say anything. Yes? You know how many projects get stalled like that? Not urgent, but important. I schedule and time block 3 hours a day for that block right there. I have to decide to put it in that box. If you don't do this, not urgent and important will suddenly become urgent and important because you left it in this box too long. And then I just get rid of all these. But if I'm done with all 3 other boxes, I give this to myself as a dessert. So this is your day. It's like a bunch of that. This is my day. All these red ones I just do, and then I defer and I schedule in this box right here. I devote 3 hours of my day every day to things I think are important. And weirdly, I might think going out to a Michelin star is important to me that day. Do you understand what I've said? So here's my day. You have 24 hours. You only have 2 12-hour blocks because you're stuck like that. I don't do that. At 6:30 a.m., I commute to the hospital. Between 7 and 8:30, I ride it on a treadmill, and that's when our post-chart morning report is. I have 5 hours of clinic. I work during lunch, and I do all those urgent, important, urgent, and not important emails. Just do. And then after lunch, I have meetings all day. I eat dinner. And I have 2 hours of block time. That's for my family. And then I go to bed, 8:30. I wake up 3:30 a.m. I have block time from 3:30 to 6:30, 3 hours of just that block time. Uninterrupted time. I have exercise built into my day, every day. All right, neuro-op, help wanted. This is what our residents say. It's too hard. There's no surgery. I'm concerned about my compensation, and that's causing time, triage, and access issues. Next available neuro-op in the United States is January 2026. I love this. It says, Dr. Lewis saved my life, 4 stars. That's neuro-op, because our wait time sucks. So literally, I save people's lives and save their vision, and they say the bathroom was dirty. Or the parking was terrible. 4 stars. Dr. Lee saved my life. 4 stars. All right, here's the demographics in the United States of neurops in the United States of America. You see where all the neurops live? This is the United States. Half our GDP comes from just these places. The whole rest of the country is the other half. That's Houston, Texas. We're the 23rd largest economy in the world. This is Texas. We're the 8th largest economy in the world by ourselves. The only state that's more, California. Unfortunately, all the neurops live in these places, which means whole swaths of our country have no neurop, none. So if you look at the factors affecting ophthalmology resident choice to pursue neurop, lack of surgery, exposure, and promoting interest, these are the things we're trying to do at the national level to get residents like you to choose us. And if you look at this paper on factors affecting, it is the perceived lack of surgical opportunities that is deterrent. So we are trying to create surgical fellowships for neurop that will pair. Because everybody talks about the weather in Canada. Nobody does anything about it. All right, so what are we doing? We have a Kaiser model, which is telemedicine. So we do a lot of after the COVID-19, it proved that we can do this. We have a pipeline to bring new neurops, and we are doing a multidisciplinary approach. We're also using neuro-optometry as physician extenders in the United States. And we are targeting recruitment, investment, and we're trying to make neurop sexy. That's my job. I'm trying to focus on the positive. Convincing ophthalmologists and neurologists at your level to choose us. Choose us. We can't force people to choose us. But I do want to dispel some of the myths. One of the myths is neurop is too hard. Just come on YouTube. You see it's not. We can do it in 3 minutes. And it's not sexy. I hope I've convinced you it's a little bit sexy. Visit me on YouTube. This is Nodal. My kid owns this site. The holding company is owned by my kid. She started it as a high school student. She came to me and said, Dad, nobody is reading those books you're writing. Nobody is reading those papers you are writing. I said, what? She says, they'll attend your lecture in person, but they will not watch it on 30-minute or an hour lecture. You have to make it 3 minutes. I said, I cannot make a 30-minute 3 minutes. She said, well, then you just don't know it as well as you think you do, Dad. I thought about that. If I can't make 30 minutes into 3, maybe I don't know it as well as I think I do. My job on YouTube is to make 30 minutes of your reading time 3. Have you get it by watching that video? Does it work? That's for you to decide. So come visit me. We make one every day. It's part of the learner's job to make these. Last year, I told Kathy we received this creator award from YouTube, recognizing the site as in the top 0.5% of all YouTube sites on the planet. Just so you get a sense of scale, this is the American Academy. This is 8 years longer than us. They have 652,000 views. The American Academy of Ophthalmology. We crushed them. I want to end and talk to you a little bit about David Brooks' second mountain. My first mountain was me. My papers, my presentations, me. But I'm on this mountain now. It's an us mountain, you and me. And David Brooks says, a purpose-driven life means finding this second mountain and climbing it. This is me. I told you I wrote these papers. I graduated fellowship right here. All these are me. I am first author, yeah. But then I decided I'm going to climb this second mountain. I am no longer on this mountain. I'm on this mountain. Look how much taller my PubMed mountain is. Last year we produced 70 papers. The year before that, 82. You understand what a second mountain can do. Just humongous increase in the numbers. In fact, we're in the top 2% for ophthalmology. So here's what I hope you'll have taken away from this lecture. Number one, your learning begins before the clinic. Pre-chart with purpose. Be Lincoln. Make a STEM. Be Churchill. Find the unifier. Use the scientific method. Hypothesis generating, hypothesis testing. I dictate in the chart so that I can give a little mini lecture to the patient and to you, the learner, so you can hear exactly what I'm thinking. The next day, the teaching continues. Heat and pressure is applied during the day, at least I'm quenching at night. Go read about it. You get to impress the patient in the pre-chart phase, the in-chart phase, and you get to impress your peers in the post-chart phase because you know the answers, because you know the questions. If you don't pre-chart with purpose, if you don't in-chart with purpose, if you don't have a hypothesis, then you'll end up being impression, ptosis, plan, ptosis, repair. Impression, recurrent ptosis after ptosis repair. Plan, repeat ptosis repair. Impression, repeat ptosis after 2 ptosis repairs, plan neuro-op. I don't want you to be a fork. Do you understand what a fork looks like now? Don't be a fork. Be katana. Bring katana. My litmus test. We go to battle. Do I want you by my side? Yes or no? We present our cases. This is my second mountain. I tell our residents, this case is reportable. I tell the medical student, this case is reportable. In the United States, the average number of applications for ophthalmology is 80 applications. 80. 80. The average number of papers that a medical student has to write to get into ophthalmology in the United States is 5, with 2 first author papers. A third of the candidates are AOA, National Honor for Ophthalmology, AOA, and our board step 2 score is 254, which is the 75th percentile. You understand how hard it is to get in ophthalmology. You've been given a great gift. Don't waste it. And they write it up, and then they write an iWiki. And weirdly, they are now quantumly entangled because future medical students will say, hey, I read this great iWiki, and Dr. Lee, guess who the author was? I'm like, I don't have to guess. Because I know we've written over half the iWikis of neuro. Or they might say this, hey, Dr. Lee, I Googled it last night. Guess what came up first? Your video on it. I'm like, exactly. My mom thinks I teach. My mom thinks I teach. Which is true, yeah. That's how I think I teach, right? Really? Here's my residence thing. However, the real way you're gonna learn is you take what I've said and you bring it in the clinic. After this Grand Rounds, we're gonna talk about neuro-op in a way that you have not ever heard it. In a way that will be meaningful and that will bring you to the clinic. Every day, it'll be you and me. I'll be there with you. And you can literally go into the hallway and watch that YouTube and go back in there and say, you know what, I've been thinking about your case and I think I know what we're gonna do. It'll be you and me. Mostly me, but a little bit of you. And you, Jim. The way you really learn is, Dr. Lee used to say, we had a case like that once. That's the way you learn. Dr. Lee wouldn't like that. Don't do that. And not that guy again. Everything is learning to me. Pre-chart, in-chart, post-chart, lecture, morning report, iWiki. It's all teaching and learning, all of it. And I thank you for your time and attention.
I just have to, close off, yes, just to let our virtual audience know that there's no Grand Rounds next week because it's the resident exam and the following week is Walter Rice, so there's also no Grand Rounds. Any questions by any of the residents? They'll have opportunity for questions later as well. So thank you so much, Andy, for giving this phenomenal talk. I learn everything, something new every time I listen to you. And just like Myrna. I'm one of your Dr. Lee fan club members. So we're gonna take a selfie with the whole group. Yeah. Thank you.
Sandra, are you gonna
Yeah,
take
we're gonna take,